Now, there was a important quality of life metric that was used in SERENA-6. And I don't know about you, but I was very impressed about the differences in patient-reported outcomes in this trial. The patients who were randomized to early oral SERD with Camizestrant had far superior outcomes in terms of their own perceived quality of life metrics compared to an aromatase inhibitor. And so how important is that in treating metastatic cancers? Should we be spending more time thinking about quality of life issues and asking our patients their feelings about this?
I agree with you that the data was extremely impressive, and I think it's an underappreciated, very important endpoint, particularly in the metastatic setting, where despite tremendous advances over recent years, we're not able to cure patients, and so the idea of giving them longer and better quality of life is of paramount importance. That's the main thing we're talking about in clinic. And I should also just remind folks that this is a double-blind, placebo-controlled, prospective randomized study. Neither the patients nor the doctors knew whether they switched or not. And the data that you're alluding to was dramatic. Within weeks, there was a huge shift in patient-reported quality of life that was durable, such that the time to deterioration in quality of life on the control arm was on the order of, I think, about 6 months, and on the intervention arm was approaching almost 2 years.
It's amazing.
My interpretation of that data, and I'm curious if you agree or disagree with this, is in a double-blind, placebo-controlled study, when the patients got off the aromatase inhibitor onto the oral SERD, they immediately felt better, right? Because the hot flashes and menopausal symptoms of joint pains were less.
Correct.
And then over time, the disease progression rate was lower. So there was less fatigue, there was less pain, there were all the things that come with even occult progression of metastatic cancer. And that's why those curves shift early and then are durable over time.
That sounds like a plausible model to explain the observation in the PRO data. Now, some of our colleagues have had some discussion about the mechanism behind this early separation in patient-reported outcomes. And they've argued, well, maybe this is simply withdrawal from the AI and has nothing to do with the oral SERD treatment attributes. Does that matter?
Not to me.
Your patients are
the patient feels better, and the AIs are difficult drugs.
It's nice to understand mechanism,
Yes.
maybe from a scientific point of view. I don't want to discount that, but if your patient's going to do better, what's not to love about that? Am I missing something there?
No, and I think it's sort of it's a perspective issue. I mean, whether it's that the AI drugs are worse in terms of toxicity or that the oral SERDs are better, it doesn't. As you said, it's almost a semantic distinction, because the patients are clearly feeling better, and it's durable, right, over years,
right,
that they're feeling better, and so for that reason, understanding the mechanism may help us in the future design better therapies and intervention, but it doesn't change, in my opinion, the impact of the data that you're alluding to.